A gout flare presents a baffling clinical paradox. A joint that appears structurally normal from the outside can suddenly produce disabling 10 out of 10 level pain. The source of this agony is hiding deep inside the joint tissue. These are monosodium urate crystals, sharp, needle-shaped structures precipitating out of the joint fluid. But the pain does not come from these needles physically poking or tearing into the local tissue. Gout is a biphasic disease. It consists of a chronic, silent accumulation of crystals over many years and a separate, explosive reaction of the innate immune system. To understand why pain shifts locations, why acute blood tests are misleading, and why dietary changes often fail to cure the disease, we have to deconstruct a flare at the cellular level. Treating gout effectively requires recognizing that the agonizing flare is merely the alarm bell for a silent, underlying physiological failure. Uric acid is a natural biochemical byproduct. The body creates it continuously as it breaks down purines from normal cell turnover and food. High serum urate is primarily driven by an inherited genetic defect where the kidneys underexcrete the molecule, regardless of dietary intake. This pathway shows the buildup. As purines break down, uric acid enters the blood, but a genetic bottleneck at the kidneys restricts its exit. When blood urate concentration exceeds its physical saturation threshold, microscopic crystals begin to precipitate directly out of the fluid. Due to gravity and lower temperatures, these newly formed crystals tend to settle in the joints of the lower body. They preferentially seek out joints with prior mechanical damage. An old ankle sprain or altered cartilage acts as a biological sink, allowing deposits to gather. This entire accumulation phase is completely silent. These crystals can sit securely in the joint capsule for months or years, ignored by the body's immune surveillance.
A patient can amass a massive hidden crystal burden over a decade without ever experiencing a single twinge of pain. Eventually, a physiological trigger breaks that silence. Sudden dehydration, viral illness, or mechanical stress alters the joint environment, exposing the dormant crystals to immune cells. The precise moment the innate immune system recognizes these alien structures, a local macrophage aggressively engulfs the sharp needle. Swallowing the crystal trips a specific biological alarm inside the cell, activating the NLRP3 inflammasome pathway. This activation releases a flood of chemical distress signals called interleukin-1 beta. These signals initiate a massive chain reaction, recruiting a swarm of white blood cells called neutrophils into the joint space. As these neutrophils arrive, they release inflammatory enzymes and cellular debris, causing the joint capsule to swell. This release of toxic enzymes, not the physical friction of the crystals, is what manufactures the intense heat and severe pain. This explains why pain seems to move, shifting from the outside of an ankle to the inside, and then to the top of the foot. The crystals are not physically migrating across the foot like moving pebbles. Instead, inflammatory fluid and immune signals spread outward through the connected joint capsule and tendon sheaths, triggering sequential alarms in the surrounding tissues. The agonizing heat and pressure are not caused by the crystals themselves, but by the massive scale and intensity of your body's own inflammatory response. Halting this acute inflammation requires very specific pharmacological interventions. If caught early, physicians use colchicine. This diagram shows colchicine molecules entering a neutrophil and binding to its internal microtubules. By freezing those internal pathways, colchicine prevents the neutrophils from moving efficiently into the joint to amplify the attack. When the inflammatory cascade is already fully established, physicians often deploy prednisone. Prednisone acts as a broad-spectrum dampener. It enters the cell nucleus and blocks the genetic transcription pathways responsible for producing inflammatory cytokines. It suppresses the established signaling network across both macrophages and lymphocytes. Both treatments share a critical limitation. Neither lowers systemic uric acid, neither dissolves the microscopic crystals. They temporarily shut down the immune alarm system, but they leave the underlying crystal deposits intact, leaving the joint vulnerable to future flares. Moving past the acute flare to actually curing the disease requires an entirely different strategy. Many patients attempt to manage gout exclusively through hydration and strict purine-restricted diets.
While lifestyle optimization helps avoid the environmental shifts that trigger flares, it does not address the underlying crystal deposits created by years of genetic urate retention. To eliminate those deposits, the medical standard is allopurinol. Allopurinol intercepts the disease by blocking the enzyme xanthine oxidase. This block causes blood urate levels to fall below the saturation threshold of 6 milligrams per deciliter. In this undersaturated environment, urate molecules slowly detach, causing joint crystals to gradually dissolve. Maintaining this continuous state of undersaturation is the only verified biological method to clear the total body crystal burden. But this intervention carries a strict caveat for specific ancestries. Patients of Korean, Han Chinese descent, and Thai ancestry face a severe hypersensitivity risk and require HLA-B5801 genetic testing before starting the medication. Curing gout isn't a one-month process. It requires sustained pharmacological compliance over many months and years. You must treat the immune response to survive the week, but you must alter the underlying biochemistry to cure the disease.